Hello my dear curious and studious students of surgery, myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Warm welcome my dear students in my surgery lecture number 48, that is the medullary sponge kidney and other congenital anomalies of the ureter and the renal functions test. In this lecture, we will cover the medullary sponge kidneys, the ectopic ureteric orifice and the special nutrition of the urinary tract, which renal function is to be done in the renal excretory system to diagnose it and to treat it. So, now the start with me the medullary sponge kidney. It is a very small topic. It is an hereditary disease of the carried by autosomal recessive gene. The basic pathology is widening of the distal collecting tubules causing cystic dilatation of the renal collecting tubules. It is usually a bilateral condition, but occasionally it may be unilateral. I am talking about the medullary sponge kidney. The complications of this medullary sponge kidney is the infection, calculi formation due to the ureterostasis in the tubules. Clinical features is it is the asymptomatic, but symptoms are seen when the condition is complicated by infection and the stone formation. And treatment is the medullary sponge kidney as such as required no treatment. Treatment is only required if it is infected and there are renal calculi. The overall prognosis is good. So, not in detail I explained here the medullary sponge kidney. Now, the next entity, next abnormality of the ureter is the ectopic ureteric orifice. In rare instances, the ureter opens at a part other than the normal ureteric orifice. This is usually due to the fact that a second ureteric diverticulum arises from the mesonephric duct later and distal than usual. Such ectopic orifice may be present in different places in both sexes. In case of the females, the ectopic orifice usually opens distal to the external sphincter, so constant dribbling and the incontinence are almost inevitable. The diagnosis can be made from history, in which a girl or a woman give history that she is dribbling since childhood. The diagnosis can be established by giving intravenous injection of the indigo carmine and placing a swab in the urethra and another in the vagina. Dear students, here is a picture of the medullary sponge kidney. You can see on your screen. This is the transections of the medullary sponge kidney. Now, I am talking about the ectopic ureteric orifice. The position of the ectopic orifice in the females into the urethra just below the sphincteric urethra, into the vagina, into the apex of the trigone, that is extremely rare. In case of males, the position of the ectopic orifice is posterior ureteroscopy and intravenous injection of the indigo carmine is helpful to detecting the ectopic ureter. The site of the ectopic positions in the ureteric orifice in the males is apex of the trigone, posterior urethra, seminal vesicle, ejaculatory duct, rectum very rarely. And the treatment in males to resect lowermost portion of the ureter and to reimplant it into the urinary bladder. And in the females, no treatment is needed if the kidney is not damaged. Now, the specialization of the urinary tract. First is the laboratory examinations. Start with the blood count, which is mandatory in every case, every disease. That is the hypochromic anaemia, leucocytosis and erythrocytosis has been seen in the urinary tract diseases. Then the second is the examination of the urine. Here is in the blood, erythrocytosis has been seen in the association with a few renal diseases also like a carcinoma, simple cyst and a hydronephrosis. Second is the examination of the urine. That is the proper collection of the urine should be done in both men and women. The urethra harbors bacteria and few pus cells, so urine specimen taken casually will be contaminated with the normal urethral flora. In men, the midstream specimen should be taken, where the microscopic examination of the urine of the sediment may reveal white cells, red cells, pus cells, crystals and the clast. For pyogenic organism, triple strength methylene blue stain is used. For acid fast bacilli, Zell-Nielsen test is the best. It reveals tubercle bacilli in 70% to 80% of the cases. It must be remembered that if urine contains pus but reveals no bacteria, no staining, that means sterile pyuria. Strongly suggests tuberculosis of the urinary tract. And third one is the cultures for bacteria. Culture and sensitivity test is a significant test, not only know the type of the bacteria but also to know the sensitivity of the bacterial type, particularly for the antibiotic therapy. Now, the next examination is the biochemical examination like electrolytes, glucose, bilirubin and hemoglobin are essential. Next, other tests of the urine like the urinary pH. Normal kidney contribute to control of the body pH by exciting the urine in the pH range of the 4.5 to 7.5. Now the cytological examinations by Papinicolor's technique is quite effective to find out the transitional cell neoplasms of the renal pelvis and the ureter or the bladder. Now the hormone test, this also helps to detect the various diseases. Estimation of the chorionic gonadotropin in urine in its testicular tumor assisted to detect presence of the or absence of the particular type of the testicular tumors. Determination of the amounts of the testosterone, estrogen and the corticosteroids, pituitary gonadotropins in the urine is helpful to detect the contents certain endocrine disorders. Now the next test is the dipsticks. Nowadays various dipsticks, that is the multisticks or leftsticks impregnated by the chemicals are used to show that these sticks change color in presence of sugar, protein, nitrites, etc. If the urine is microscopically clear and negative on the dipstick testing, the chance of the finding of these elements in urine is negligible. Now the next is the renal function test. It must be remembered that about the 75% of the kidney function should be lost for the following test to become the positive. So renal damage must be considerable before changes occurs in blood constituents. Renal damage is mainly three types which are reflected in renal test. These are: first, reduction of the renal plasma flow as found in the renal artery stenosis or severe hypertension. Second is the dissection of the glomeruli which becomes evident in acute cortical necrosis and glomerulonephritis. And third reason is, the third test is the impairment of the tubular functions as evident in the pyonephritis. In obstructive nephropathy, back pressure on the renal parenchyma causes all these three types of the damages. Now the subtype of this renal function test is the urine specific gravity. Normal kidneys are considered urine about 1.040 at the age of 40 years and 1.030 at the age of 50 years. Now the second point is the blood urea level is normally between 3 to 6.5 mmol per liter or 15 to 40 milligram per 100 ml of blood. When urinary tract is normal or unobstructed, the plasma urea and the creatinine ratio is 10:1. Urea and creatinine ratio is 10:1. If this ratio is rises to 20 or above, it indicates urinary stasis and diminished renal blood flow. In adults, the upper limit of the blood creatinine is 1.4 milligram per 100 ml. Blood creatinine is a sensitive test of the renal function. Now the renal function test is the endogenous creatinine clearance. This endogenous creatinine clearance, the creatinine clearance is roughly equal to the twice of the excretion of the PSP in the first half an hour. Now the next test is the PSP test. The PSP test is the test of the renal blood flow and tubular function. Next test is the serum electrolytes. Estimated the various serum electrolytes gives suggestions as to the status of the renal functions. Now these are the blood and urine tests. Now the röntgenic examination, that is the radiology. First is the straight X-ray, preparation of the patient for the straight X-ray for the renal system. No food or fluid should be taken into the to the patient by the patient for at least 6 hours before the X-ray examination. A purgative is given at the night before, so there is no chances of the shadow of the gases and fluids if the purgation is given before night. Excited radiograms, that is the IVP, intravenous pyelography. The radiopaque fluid is injected intravenously. Generally high-pack sodium dietrozoate or urographin is injected. Adult dose is about 20 to 25 ml. X-ray radiogram is physiologically as well as the anatomically test, since it not only determines the function of the kidney but also clearly demonstrates the contour of the renal pelvis and calyces too. Nephrotomography, accurate visualization of the kidney and the pelvic LL system is possible by this technique. Dear students, here is the image showing the radiology and the renal imaging like the plain X-ray radiograph of the abdomen, intravenous pyelography, ultrasonography, then computed tomography, CT scan, radionuclide studies are the radiological renal examinations. Now the third is the retrograde urogram. Indication for the retrograde urograms are inadequate excretory urograms which have failed to demonstrate the pelvis, renal pelvis, calyces and the ureters adequately. These investigations will be required. Second is the impaired renal function which has failed to show the pelvis and calyces. This test is needed. Third is the sensitivity to intravenous contrast medium is to definite indication for the test. And the fourth is the if pyuria is present. Fourth is the antegrade urogram, that is the AGU. The clinician indication for this test is inadequate information from intravenous urogram with an unsuccessful or impossible retrograde examination Under fluoroscopic or ultrasonic control, an 18 per gauge needle 15 cm long should be passed into the dilated calyx of the pelvis of kidney. Radio opaque dye should then be instilled and appropriate films are taken. It is better to pass the needle into the dilated calyx rather than the pelvis, as there will be the better seal round the needle's track and the less danger of puncturing the large hire of the vessel. So, there is no danger of the bleeding. And the fifth is the cystograms, excitatory cystograms, retrograde cystograms and voiding urethograms are essential as increase intravesical pressures. Next is the renal angiography. Although renal angiograms can be performed by direct lumbar needles punctures of the aorta, yet this technique has been superseded by the percutaneous femoral angiography. And next is vesical angiography. A Seldinger's catheter is passed to the bifurcation of the aorta and 30 ml of the 90% of the contrast medium is injected. Next investigation of the renal test function is the lymphangiography. A lymphatic vessel in the foot is cannulated and the oily contrast medium is injected. This leads to opacification of the inguinal pelvic aortic groups and the supraclavicular lymph nodes. Metastatic infiltration can be demonstrated in regional lymph nodes by filling defect in malignant tumors of the testes, prostate, bladder and the penis. Next test is the angionephrotomograms, that is the intravenous renal angiogram. In this investigation, a bolus of the radio opaque medium, that is the 30 to 50 ml of 90% of HIPEC is injected inside a vein, antecubital vein rapidly. 4 to 6 tomograms are taken. Space occupied by a cyst or abscess fails to opacity, whereas a malignant tumor shows a normal or increased opacification. Renal angiography is however better. Investigation is the ultrasound. Any change of the renal outline and displacement of the fragmentation of the collecting system of echoes is of pathological significance. With ultrasound, agenesis, hypoplasia, duplex or ectopic kidney can be diagnosed. In the evaluation of the renal masses which are found and at excision, urography ultrasound is firmly established as the next investigation. And next investigation is the transrectal ultrasonography. This mode of the investigation is now very commonly used in case of the suspected carcinoma of the prostate and sometimes in benign hyperplasia of the prostate. One can also take transrectal needle biopsy while performing this investigation. Now, the next investigation is the computed tomography, that is the CT scan. A swelling in and around kidney is well determined by the CT scan. Renal calculi are readily demonstrated. Hydronephrosis can be seen if gross. Pararenal masses are also finely demonstrated. Lymph nodes between the renal hilum and the diaphragm are not adequately visualized by the lymphography. Staging of bladder tumors, the degree of the muscle invasion by carcinoma of the bladder has an important prognostic significance. Next is the radioisotope renography. 100 Ci of I-131 labeled heparin is injected IV. Function of the kidney is very well assessed with this technique. Technetium 99M labeled DMSA is often used nowadays. This vein is injected intravenously and scanned by the gamma camera will provide more information regarding renal plasma flow. Similarly, 99M DTPA scan is excited earlier and gives a good image of the renal outline. Nowadays, the DTPA scan is very popular. Now, the next is the renal skin test scan. This consists of the measuring the rate of the accumulation of 197 Sg labeled neohydrin using an external detector up to the 1 hour after the injection. Then the next investigation is the magnetic resonance imaging, that is the MRI. The principle of the MRI has been discussed in the radiology separately. It is agreed that the MRI is potentially the powerful and versatile imaging techniques in the medicine field. There are many advantages of MRI, like it uses no ionizing radiation, so no harmful genetic or somatic effects. No bowel preparation with fluid or food restriction is necessary. Contrast media are not required to distinguish the gastrointestinal tract or vascular structures. Paramagnetic contrast agents are now being developed that should enhance the advantage of MRI in near future. It offers great flexibility for imaging in many planes, that is the sagittal, coronal and the axial planes. The images produced are superior to that obtained from ultrasound. It gives better information about soft tissue than any other imaging methods. Disadvantages of the MRI are it has a low sensitivity for calcified lesions. Image acquisition takes longer time than CT scanning. The apparatus is larger and expensive. As strong magnetic fields is used, strict security measurements are needed to prevent injury due to the loose metallic objects. being drawn to the magnetic fields. Pacemakers can be exposed to the powerful magnetic fields used in the MRI. Dear students, here we cover the all types of the renal function test which has been done in the renal system. I think you are sufficient to better understand. By this your concept is now clear. You can watch very good videos on YouTube. Here is the end of our surgery lecture number 48, that is the medullary sponge kidney and the renal function test. Thank you.